Triage. Triage is the process of determining the priority of patients' treatments based on the severity of the condition. This ration patient treatment efficiently when researches are insufficient for all to be treated immediately, influencing the order and priority of emergency treatment, emergency transport or transport destination for the patient. The term comes from the French verb trier, meaning to separate, sort, shift, or select. Triage station, Supis, France, World War I. Modern medical triage was invented by Dominique Jean Leray, as a surgeon during the Napoleonic Wars, who treated the wounded according to the observed gravity of their injuries and the urgency for medical care, regardless of their rank or nationality. So the general concept of prioritizing by prognosis is first out in the 17th century BC Egyptian document. Triage was used feature during World War I by French doctors treating the battlefield wounded at the a station behind the front, those responsible for the removal of the wounded from a battlefield or their care. Afterwards, Wolves divided the victims into three categories: those who are likely to live regardless of what care they receive, those who are unlikely to live regardless of what case they receive it. Uh, those for whom immediate care might make a positive difference in outcome. For many emergency medical service systems, a similar model may sometimes still be applied in the earliest stages of as incidents, such as when one or two paramedics access to 20 or more patients practically demands and that the above or more primitive model will be used. However, once a full response has occurred and many hands are available, paramedics will usually use the model included in their service policy and standing orders. As medical technology has advanced, so have modern approaches to triage, which are increasingly based on scientific models. The categorizations of the victims are frequently the result of triage scores based on specific physiological assessment findings. Some models, such as the START model, may be algorithm-based. As triage concept become more sophisticated, triage guidance is also evolving into both software and hardware decision support products for use by caregivers in both hospitals and the field. Simple triage is usually used in a sense of an ascended or mass casualty incident in order to sort patients into those who need critical attention and immediately transport to the hospital and those with less serious injuries. This step can be started before transportation become available. Upon completion of the initial assessment by physicians, nurse, or paramedical personnel, each patient may be labeled, which may identify the patient, display assessment findings, and identify the priority of the patients needed for medical treatment and transport from the emergency scenes. At its most primitive, patient may be simply marked with colored flagging tape or with marker pens. Pre-printed cards for this purpose are known as a triage tags. Triage tags. Many triage systems use triage tags with specific format. A triage tag is a prefabricated label placed on each patient that serves to accomplish several objectives. Identify patient, be a record of assessment findings, identify the priority of the patient needs for medical treatment and transport from the emergency sense. Track the patient progress so the triage process, identify additional hazards such as contamination. Triage tags may take a variety of forms. Some countries use a nationally standard designed triage tag, while in other countries commercially available triage tags are used, and this will vary by jurisdiction choice. The most commonly used commercial system includes the MedTag, the SmartTag, ET Light Team, and the Cruciform system. More advanced tagging systems incorporate special markers to indicate whether or not patients have been contaminated by hazard dose materials, and also a tier of strips for tracking the movement of patient through the process. Some of these tracking systems are beginning to incorporate the use of handheld computers, and in some cases bar scanners. In advanced triage, especially trained doctors, nurses, and paramedics may decide that some seriously injured people should not receive advanced care because they are unlikely to survive. It is used to divert scare researchers away from patients with little chance of survival in order to increase the chances for others with higher likelihoods. The use of advanced triage may become necessary when medical professionals decide that the medical resources available are not sufficient to treat all the people who need help. The treatment being prioritized can include the time spent on medical care or drugs or other limited researches. This has happened in disasters such as terrorist attacks, mass shootings, volcanic eruption, earthquakes, tornadoes, thunderstorms, and rail accidents. In these cases, some percentage of patients will be regardless of medical care because of the severity of their injuries. Others would live if given immediate medical care, but would die without it. In these extreme situations, any medical care given to people who will die anyway can be considered to be care withdraw from others who might have survived or perhaps suffered less several disability from their injuries. Had they been treated instead, it becomes the task of the disaster medical authorities to set aside some victims as hopeless, to avoid trying to save one life at the expense of several others. If immediate treatment is successful, the patient may improve. Also, this may be temporary, and this improvement may allow the patient to be categorized to allow priority in the short term. Triage, triage should be a continuous process, and categories should be checked regularly to ensure that the priority remains correct given the patient's condition. A trauma score is invariably taken when the victim first comes into hospital, and subsequent trauma scores are taken to account for any change in the victim's physiological parameters. If a record is maintained, the receiving hospital doctor can see the trauma score time series from the start of the incident, which may allow definitive treatment early. Usually, triage refers to prioritizing admission. A similar process can be applied to discarding patients, usually when the medical system is stressed. This process has been called reverse triage. When a major wave of patients arrive to a hospital, such as immediately after a natural disaster, many hospital beds will be already occupied by regular non-critical patients to accommodate a greater number of the new critical patients. The existing patients may be triaged, and those who will not need immediate care can be discarded until the surge has dissipated. For example, through the establishment of temporary medical facility in the region. Under-triage is underestimating the severity of an illness or injury. An example of this would be categorized a priority first, immediately patient as a priority 2, delayed, and priority 3, minimal. Historical acceptable under triage rates have been deemed 5% or less. Over triage is the overestimating of the severity of an illness or injury. An example of this would be categorizing a priority 3 minimal patients as a priority 2 delayed or priority first immediately acceptably overtage rates have been typically up to 50 percent in an effort to avoid under triage. Some studies suggest that over triage is less likely to occur when triaging is performed by hospital medical teams rather than paramedics or EMTs. In telephone triage, decision makers over the phone must effectively access the patient's symptom and provide directives based on the urgency. This should be done in a timely fashion while meeting standard guidelines lines in order to prevent symptoms from worsening. For patients that have a poor prognosis and expected to die regardless of the medical treatment available, palliative care such as painkillers may be given to ease suffering before they die. Evacuation. In the field, triage sets priorities for evacuation or relocation of other care facilities. During the early stages of an incident, first responders may be overwhelmed by the scope of patients and injuries. One valuable technique is the patient assist method. The responders quickly establish casualty collection point and advise user by yelling or our loudspeaker that anyone requiring assistance should move to the selected area (CCP). This does several things at once. It identifies patients that are not so severely injured that they need immediately help. It physically clears the sense and provides possible assistance to responders. As those who can move do so, these responders then ask anyone who still needs assistance, yell out of or raise your hands. This feature identifies patients who are responsive, yet may be unable to move. Now the responders can repeatedly assess the remaining patients who are either expectant or are in need of immediate aid. From that point, the first responder is quickly able to identify those in need of immediate attention while not being distracted or overwhelmed by the magnitude of the situation. Using this method assumes the ability to hear. Deaf, partially deaf, or victims of a large blast injury may not be able to hear these instructions. In Western Europe, the triage revisit trauma score TRTs is sometimes used and integrated into triage scales. The injury severity scores is another example of a trauma scoring systems. This assigns a score from 0 to 75 based on severity of injury to the human body divided into three categories: A. Face, neck, head; B. Thorax, abdomen; C. Extremities, external skin. Each category is scored from 0 to 5 using the abbreviated injury scale, from injured to critically injured, which is then squared and summed to create the ICC. A score of 6 for unservable can also be used for any of the three categories and automatically sets the score to 75 regardless of other scores. Depending on the triage situation, this may indicate either that the patient is a first priority for care, or that he or she will not receive care owing to the need to conserve care for more likely survivors. Start. Simple triage and rapid treatment is a simple triage system that can be performed by lightly trained lay and emergency personnel in emergencies. It is not intended to supersede or instruct medical personnel or technicals. It has been taught to California emergency workers for use in earthquakes. It was developed at Hawk Hospital in Newport Beach, California, for use by emergency services. It has been failed proven in mass casualty incidents such as train wrecks and bus accidents. So it was developed by community emergency response teams (CERS) and different firefighters after earthquakes. Start. Triage separated the injured into four groups: the expectant, who are beyond help; the injured, who can be helped by immediate transportation; the injured whose transport can be delayed; those with minor injuries who needs help less urgently. Triage also sets priorities for evacuation and transport as follows: decided, decisive, left where they feel. This includes those who aren't bracing and repositioning their airway efforts where unsuccessful. Immediately or priority first red evacuation by medevac if available, or ambulance as they need advanced medical care at once of within 1 hour. These people are in critical condition and would die without immediate assistance. Delayed or priority 2, second yellow, can have their medical evacuation delayed until all immediate people have been transported. These people are in stable condition but require medical assistance. Minor or priority 3 green are not evacuated until all immediately and the light person have been evacuated. This will not need advanced medical care for at least several hours. Continue to triage in case their condition worsens. These people are able to walk and may only need bandage and antiseptic. The Jumpstart Pediatric Triage MCI Triage tool is a variation of the START model, but systems are used to sort patients into categories at mass casualty incidents. However, Jumpstart was designed specifically for triaging children in disaster setting. So Jumpstart was developed for use in children from infancy to age, where age is not immediately obvious. It is used in any patient who appears to be a child. Patients who appear to be young adults are triaged using START. Hospital systems. Within hospital systems, the first stage on arrival at the emergency department is assessment by the hospital triage nurse. The nurse will evaluate the patient's condition as well as any changes and will determine their priority for admission to the emergency department and also for treatment. Once emergency assessment and treatment are complete, the patient may need to be referred to the hospital internal triage systems. For a typical inpatient hospital triage system, a triage nurse or physician will either field request for admission from the ear physician on patients needing admission or from physician taking care of patients from other floors who can be transferred because they no longer need that level of care. Intensive care unit patient is stable for the medical flow. This helps patient flow more efficient in the hospital. This triage position is often done by a hospitalist, a major factor contributing to the triage decision is the available hospital bed space. The triage hospitalist must determine in conjunction with a hospital bed control and admission team what beds are available for optimal utilization of such in order to provide safe care to our patient. A typical surgical team will have their own system of triage for trauma and general surgery patients. This is also true for neurology and neurosurgery service. The overall goal of triage in this system is to both determine if a patient is appropriate for a given level of care and to ensure that hospital research is utilized effectively. Conventional classification. In advanced triage process, injured people are sorted into categories. Conventional, there are 5 classifications with corresponding colors and numbers. Also, this may vary by region. Black, expectant. There are so several injured that they will die of their injuries, possibly in hours or day, large area burns, severe trauma, lethal radiation dose, or in a life-threatening medical crisis that they are unlikely to survive given the care available. Cardiac arrest, septic shock, severe heat and, or chest wounds. Their treatment is usually palliative, such as being given pain-like layers to reduce suffering. Red immediately. Red immediately. They require immediate surgery or other life-saving intervention and have first priority for surgical teams or transport to advanced facility. They cannot wait but are likely to survive with immediate treatment. Yellow observation. Their condition is stable for the moment but requires watching by trained response and frequent triage. Will need hospital care and would serve immediate priority care under normal circumstances. Green weight, green weight, walking wounded. They will require a doctor's care and several hours or days, but not immediately may wait for a number of hours or be told to go home and come back the next day. Broken bones without compound fractures, many soft tissue injuries. White dismiss walking wounded. They have minor injuries, first aid and home care is sufficient. A doctor's care is not required. Injured, Injuries are along the lines of cuts and scrapes or minor burns. Thank you for your attention. The end. Goodbye.